There are three types of hysterectomies traditionally. There is abdominal hysterectomy, there's vaginal surgery, and then there's laparoscopic surgery. Laparoscopic surgery is putting a telescope into the abdomen, usually through the belly button, and then we can use other additional instruments to perform the surgery through small holes. The difference between conventional laparoscopy, which uses 3 or 4 or sometimes 5 small holes in the abdominal wall, is with single incision laparoscopic surgery. All of these instruments can then be put in through one small incision in the belly button. We can place these 2 or 3 or 4 instruments through one port, one incision in the base of the belly button. We don't make any of those extra punctures. We're not going through any of the muscle, and we can keep everything right in the belly button. For the procedure, we usually identify the patient's belly button. Everybody's belly button looks a little bit different, and we try to match the incision to hide it best in the belly button. The incision for the belly button in these ports usually is between maybe 2 centimeters to 3 centimeters. We try to bury it, just for cosmetic reasons, bury it deep inside the belly button. We fill the belly with gas, we look around, we look to make sure that there's nothing unexpected, and then we'll complete the hysterectomy. For the post-op recovery period, I would say that the average is probably about 1 to 2 weeks, with it being dependent on the patient's response. The benefits of single incision surgery, I would say first is that you only have one incision through the abdominal wall. One incision means there's only one place where there's a risk of infection or bleeding. Number 2, there's no risk of injury to any of the other nerves or vessels that lie lower in the abdominal wall. And number 3, perhaps less pain. 5mm ports don't create a lot of pain, and so right now we're splitting hairs. And number 4 would be cosmetics. Clearly with these types of incisions in the belly button, this can leave no trace. Anytime that a patient would come to a surgeon, there's questions they should ask is what's their training overall, and then what is their training specific to this procedure? How long have they been doing it? How many have they done? And more importantly is how many are they doing on a regular basis? If a physician has done a handful, then they should be upfront and they should tell the patient, I've done a handful of these. A lot of physicians say, why should we do laparoscopic surgery through one small incision when the other small incisions are so small anyway? But I think that as we look to the future, in this situation, if we can do the same surgery without increasing the risk, the question shouldn't be, why should we do this, but why not?